We're going to continue talking about acid-base physiology. And in this lecture, we're going to focus primarily on metabolic alkalosis. And alkalosis implies a pH that's greater than 7.45, and a primary metabolic process implies that some interaction is taking place with the bicarb. And in this case, you have an increased bicarb with metabolic alkalosis. And we can say that the primary pathology of metabolic alkalosis can either be an increased mineral corticoid activity, which therefore you have an increased sodium chloride concentration, and it's also termed as chloride-resistant metabolic alkalosis. And on the contrary, you can have a sodium chloride deficiency, in which you have a decreased concentration of sodium chloride, and it's coined and termed chloride-sensitive. So certain examples of increased mineral corticoid activity would be hyperaldosteronism, in which there's an increased release of aldosterone, which, as we know from renal physiology, involves the regulation of sodium ions. So we can see here, if there's an increased aldosterone activity, in which aldosterone is released from the adrenal gland and goes into the collecting tubules, if this is considered the nephron, and we can see here that you have the glomerulus that goes to the proximal convoluted tubule, loop of Henle, distal convoluted tubule, and now you have the collecting tubules. In the collecting tubules, there's activity of aldosterone that's released from the adrenal gland, comes in through the capillary system, and has interaction on the principal P cells of the collecting tubules. And that allows for the reabsorption of sodium from the lumen of the collecting tubule back into the capillary system, and therefore becomes the concentration of sodium. And as you have increase in sodium, chloride also tends to be reabsorbed. So we can see here that with the process of increased aldosterone activity or increased mineral corticoid activity, you may develop a chloride-resistant metabolic alkalosis. On the opposite effect, if you have a deficiency of sodium chloride, for example through GI and the renal system, if you were to have vomiting and diarrhea and losing chloride, or for example unable to reabsorb the sodium because of diuretics, which happens to be the most common cause of metabolic alkalosis, you're going to see how you can develop abnormalities in the acid-base system. So here we'll look at the graph here. As we talked about earlier, alkalosis implies a pH that's greater than 7.45, and the increase in bicarb implies metabolic alkalosis. Now, as far as the compensatory mechanism, the lungs try to compensate for the metabolic alkalosis through a process of hypoventilation, in which there's an increase in partial pressure of carbon dioxide. So through the decrease in alveolar ventilation or hypoventilation, you're going to increase the amount of carbon dioxide within the systemic circulation. And treatment for metabolic alkalosis depends upon whether you had the increased mineral corticoid activity, for example, the increased activity of aldosterone. You would treat that by an aldosterone antagonist, for example, spironolactone. And therefore you're going to decrease your sodium reabsorption in the collecting tubule, in the P cells. Or if the cause of metabolic alkalosis is from sodium chloride deficiency, you're simply going to treat it by infusing normal saline, which is sodium chloride, and potassium chloride as far as replacement. And if one of the causes of metabolic alkalosis was through GI, for example, vomiting or diarrhea, you may want to treat it by an H2 blocker for the GI fluid loss. So this, once again, explains metabolic alkalosis. The alkalosis implies a pH that's greater than 7.45, And the primary metabolic cause of the alkalosis implies an increased bicarb concentration. And the compensatory mechanism of metabolic alkalosis takes place by the pulmonary system, which is hypoventilation or decreased alveolar ventilation, which increases the acid within the system in the form of carbon dioxide, and that helps to regulate the pH closer to the normal value of 7.35 to 7.45. One of the interesting factors of metabolic alkalosis is it's one of the most difficult acid-base disturbances to correct. And the reason why is because the degree of hypoventilation or the degree of compensatory mechanism by the lungs is limited, because as you hypoventilate and build up your carbon dioxide, you're obviously going to decrease the oxygenation or gas exchange of oxygen from the alveoli into the capillary system. So because of hypoxemia and desaturation, it's going to limit the degree of compensatory mechanism of hypoventilation in a metabolic alkalotic environment. In the next lecture, we'll talk about respiratory alkalosis. We'll talk about certain causes of respiratory alkalosis, and we'll talk about the treatment plan for respiratory alkalosis.